for restoring the full arch, fixed versus removable prostheses, or rather I should say semi-fixed prostheses. Why? Well, let me go into the solution. So in Zimmer Biomet, we always believe in taking our dentist or our people who believe us. We always believe in moving them forward, but that is only possible when we changes the life. So today I will going to talk about the people who are elderly, who are having solution of who are having a problem of edentulism, and which part of which part of our learning today and the things which I'm going to share with you is going to change their life. So, well, we all know edentulism is prevalent right now. We all know that there are a lot of advancement in the technology which we can save the teeth. But I want to highlight some data. Even though the edentulism case is declining at the rate of 10%, but with the elderly, with the longevity of the patients is increasing day by day. So if you expect in the year 2025, you might see 80% increase in the adult population. So we are going to definitely see edentulism cases more because of the more percentage of the elderly people in the various developed countries. So this data which you're seeing right now in the screen, that is not even like from the developing nations, it's from the developed nations. The reason being because the age of the people greater than 65 years of is increasing day by day. So now, is whether edentulism is a scenario which is considered is like a handicap? Well, according to WHO, edentulism is basically considered as a physical impairment. And why? Because if you see the person here, the left side, you are seeing an X-ray in which you see that the bone is dissolving continuously. So it is 100% the solution which is of denture available currently. It is not self-sufficient because the rate at which the denture is the bone is dissolving because of this pressure from the denture, it is making the patient vulnerable to perform their daily routine task, which is basically eating. Now, in the further slide, I'm going to show you different type of force dynamics, which we have to understand to understand and to make them to set the expectation of the patient correctly whenever we are trying to provide them a solution based on their expectation or based on their budget availability. So we all know there are various reasons of the tooth loss, whether it is diet, whether it can, because of the poor health, because a lot of comorbid condition is available. There are people who are financially also challenged because of that. And what can lose if the teeth is lost? They can also gradually with time, there will be a lack of self-confidence, and then with time they have a lot of even the physical impairment, even the their health will slowly deprive, and they will not have proper nutrition from the food which they are getting. So there are a lot of disadvantage of the tooth loss. But I want to highlight one specific effect. You see in the picture here, if the tooth is not there, we all know, we all have studied Wolff's law. Wolff's law says that if there is a pressure on the bone will get dissolved with time. And if you see here, the left side you can see the female candidate, and the right side you can see the male candidate. Both the candidates, if the bone is dissolved, slowly they will be started looking older. And you all know that how much the appearance matter to many patients, because as they started looking older, their psychology, their daily routine, their the whole life will be impacted altogether. So this is what I wanted to highlight. Apart from that physical impairment and all, they also have a psychological impairment also. And with this, if you see not the physical, you can see that change, that the wrinkles will start appearing on the face, and the patient start looking older. And on the contrary, if the teeth is prevented somehow, and the teeth is there in the mouth in the patient, or if the teeth is restored correctly, that will direct to the anti-aging dentistry, and the patient will start feeling younger. They will have the new vibe in their life, and then they will enjoy the life back. So now there are something which is very much important to consider before giving the denture to the patient. So whenever the patient is coming to you, there are something which is very much important. In the coming around 7 to 8 slides, I'm going to cover this particular factor, that what are the things to be considered when the patient comes for the denture. And it is our duty as a dentist to tell them what are the solutions available nowadays and why they have to take the decisions now only before giving the denture. Because in the previous slide I have showed you that denture is not expensive, is not a least expensive solution, because if this solution is making your bone dissolve, it is not a right solution for you, because in the future this will limit our solutions and we will have lesser options available even if the patient is ready to pay. If there is no bone, we cannot do anything. So in the coming slide, we will discuss on those part. We all know the disadvantage of denture, which I have already highlighted in the previous slide. Okay, this will basically reduce the quality of life, and of course, their confidence will be lower, and patient will not able to speak properly. They will not able to eat properly because of the less force dynamic. I'm going to show you in the further slides. But before going to the thing and before going to the in the detail about that, I wanted to highlight the two major difference which we all know, which even I think the layman, even our normal patients can also understand, that whenever patient comes to you and they have financial capacity, they always prefer fixed. Okay, that is the first choice for them. They wanted to have the teeth which they looks very much close to the natural teeth, and that is the fixed solution available. And whenever you use the word removable, which that normally they will not prefer. They think that removable, it is very much like a denture. Okay, so it's very important for us. Here today, I am going to compare the removable processes, which is basically a overdenture, which is basically the patient can remove by themselves and they can take out from themselves and they can clean it. In some cases, those solution is important, and that is imperative for them. At times, it is you will find a case in which the fixed solutions will not solve the problem, but the removable solutions will do that need. So we have to understand both of these things, and we have to clarify this at the first stage or maybe in the second appointment with the patient, so that we can plan it properly. Now, so fixed solution, it definitely is a first choice for the patient, that we all know. Phonation is a little bit problematic, and in the removable, it is easier. You know why I'm saying this thing? Because the day one, when you give the fixed prosthesis, the patient will not able to remove that prosthesis. So initial days will be tough. Patient have to adapt whenever they want to speak, and when they have to talk, because suddenly in between the tongues and the lips you have a restoration which you cannot remove. So you have to adjust with the phonation part, with the fixed prosthesis. But when you talk about the removable option, which I am saying to be a semi-fixed, why I am using this particular phrase semi-fixed, because the patient psychology works that way. If you say removable, they will will never ever think about that. Their subconscious mind will always direct them to choose fixed option. But when you say semi-fixed, it will make them think that, okay, this is a solution which is also fixed, but you have to sometimes remove it. Okay, and that is because of the patient's own bone availability or patient's own factor. Okay, so that is why I'm using semi-fixed words. And so here you will see the problem in adjusting the speech is lesser. Okay, now gag reflex, we all know that patient having gag reflex, the fixed restoration will be a fewer problem, but in removable, yes, you have more problem, because definitely it touches the palate and it works on the suction principle. Okay, oral hygiene, you know that oral hygiene, it is more demanding in the fixed. Okay, and the removable one, it is easier to clean. You can just remove and you can clean it. And yes, the removable option is least expensive. Okay, so that is all we all know. So we are on same page. That's why I just discussed this point. Now I want you to understand the force dynamics now before going to the further slides. Denture patients or denture wearer patients will hardly observe 50 lbs force. Now, I wanted to give you an idea, like normal, like what we eat, the food, the natural teeth, normally they can exert force which is around 500 to the range of 500 pound. So normally, like in the morning, we all had a breakfast. So in that breakfast, or we had a lunch right now. So whenever we eat our food, we are normally applying the force which is around 500 pound. Now imagine you reduce the force by 1/10. That is the force which a denture patient can apply, and that too at the cost of dissolving their own bone. So the denture is not giving the enough force, number one. Number two, the denture is also making the bone resolved. That is the problem. So people who consider denture to be the least expensive, well, they are wearing the denture at the cost of losing the bone actually, and they cannot eat the food properly because of this 10% force, and that is the issue. Now, if we talk about implants, so we have a semi-fixed solution, which we call it an overdenture solution. In that, you are able to deliver 450 pounds, which is very much close to the natural dentition. So that is what we are going to talk about in our upcoming slides. Okay, so this, I hope you all are clear now in the different type of force dynamics. So this is what the same thing we are trying to make you understand, like overdenture or fixed removable also in the picture. So if you see here, the overdenture can also give the force, but not exactly like a fixed removable. The force is a bit lesser. Why? I think you will understand when we are going to show you the different type of overdenture solutions. But just to give you a gist, that in overdenture, you are not removing the flanges. You are still, our denture is still taking the support from the soft tissue around it. So because of that support, that force will be comparatively lesser compared to what your fixed removable prosthesis is giving. In fixed prosthesis, basically all the force will be transferred on the implants. Okay, there is no soft tissue support in that. So now again, the same force dynamic part which I discussed with you all. Here, if you see the whole natural teeth, for example, if we do the rating around from 0 to 100, you can keep the denture very much near to the like no teeth condition. You won't believe, in India we have some patients who don't even need teeth. They are so much irritated from the denture that they have stopped using the denture, and they said that better I will chew without denture only. So they are so much fed up from the denture. So no teeth or denture, sometimes it performs well. Well, see, I am not questioning. See, in even 15 years, 20 years, we are giving the ideal dentures. We are giving the denture with the proper border molding, proper fitting and everything. So I'm not criticizing those denture. I'm talking about denture in general. And basically, I am talking about the lower denture. I know maxillary denture, you will have the fitting because of the suction and everything, but in mandible it will impact. So whatever I am talking about, the bone dissolution part, I'm talking about that is more in related to the lower denture. Okay. That is why even in this study by Andres, we have highlighted the lower denture part. And now we talk about the implant overdenture. In the implant overdenture, you can see that it can give you the efficiency compared to the natural teeth, around 60% of efficiency. So if you consider natural teeth to be the 100% efficient, implant overdenture will be the 60% efficient compared to that. So again, what will happen normally when the teeth is not there? You give the denture will apply some pressure. Slowly the bone get dissolved. So that is what we understand. And very much important, doctors here, that you have to explain to the patient that this happened. See, many times patients think that your denture is getting loose because of it is made up of plastic. But no, it is the bone of the patient which is getting dissolved. It is always better to keep some x-rays of a patient for, let's say, 2 years, 5-year follow-up, and then show to the patient to make them understand these things. Because at times patients don't understand. Patients think that it is because of the material, that your denture is loose, you are not giving me the correct material, stuff like that. Better to counsel the patient in the first appointment itself. And you all know the patient will end up in using the glue in order to get the normal fitting, and that is advised. But there are negative impact of using different type of denture adhesive, denture glue available in the market. Now, coming to the appointment when the patient is coming to you. So the first thing first is that you have to keep understand the patient, how much they are willing to spend. Okay, so it's better to discuss them verbally, like what they are willing to spend. So this will give you the fair idea like what type of processes you can talk about with the patient. Second thing comes is the CBCT, because nowadays there is CBCT is the gold standard. You have to understand how much bone is available. See, patient can ask stars in the moons, or they have like thousands of dollars to spend. But if they don't have the bone, what you can do? You cannot just create the bone there and all stuff like that. So we don't have that much advancement in the thing. If the fully dentulous case, you can just do the vertical, full arch vertical augmentation. That is not possible yet. So understanding the bone, it is very much important. After that, the model preparation is something which is very much helpful. Many dentists do that. During the counseling session only, they have a CBCT in the laptop, they have the models ready, and in the models, they will also have the different types of existing denture available. We have now flexible denture available, we have the overdenture solution available, we have the screw retained fixed denture sample available. So it's always better to show them all these solutions so that they can touch, they can feel, they can understand that in the remaining part of the life, they have to spend their life with these solutions. It is always better to spend ample amount of time in this stage rather than spending the time in correcting the mistakes later. So many senior prosthodontists, senior dentists will agree on that part, and we have a little discussion in that. Even if it takes 2 appointments, 3 appointments for patient counseling, it is better to do it. I'm going to show you one case in which it took 3 years. In 3 years, where to follow up the patient, and then I will talk about it in the coming slide later. But this is something which we should do in our first appointment itself. Existing denture evaluation, it is very much important. Inter-arch availability is very much important. Inter-arch availability, I will discuss in the coming slides. Like it, based on the distance between the 2 arches, what is the solution you should discuss, you should advise. Evaluation of existing denture, it is very important because there are some solutions which I'm going to talk about in the coming slide. It is like in which you can even give the temporary denture solution in the same day of the implant placement. So at that particular time, you have to check the existing denture, it is capable of being in the mouth for a certain period of time or not. So that is also important. And then, of course, this is a part of a patient counseling, understanding the patient's psyche and then advising. Now, based on that, what are the solutions which we have? So we have a conventional denture, of course, when nothing is working, you have the conventional denture available for the patient use. We have the tissue supported or implant retained overdenture. We have it. We have implant supported bar overdenture also. Means we have a bar in the bottom and then we can give the denture which is supported by the bar. Means the patient remove the overdenture, but the bar will be fixed in the patient mouth. So that is basically an implant supported overdenture. Then we have implant supported fixed hybrid prosthesis. So in this one, patient cannot remove it. This have to be removed under the dental supervision or by the dentist there. Or finally, we have the fixed prosthesis available, which is of course of various type, and it is beyond the scope of today's discussion. We have a CAD-CAM bars available. We have the Malo bridge available. We have multiple things available. So now this is what I was talking about, the inter-arch space. So ideally, the inter-arch, which should be like for any solution, that is 12 to 14 mm. So between the upper arch, maxillary arch, and the mandibular arch, you should have 12 to 14 mm space, which so you can choose between this overdenture or you can choose between the fixed hybrid denture. So that is, you can choose easily when it is there. But now the question is, when if it is more than 14 mm, then you have to go with the fixed prosthesis, or if it is greater than 15 mm, that is suitable for fixed hybrid prosthesis. And minimum, if you go in the minimum, means the too much bone is there. Too much bone is there. The patient have recently lost the teeth, and you have inter-arch space which is very less, around 8 to 10 mm. Then, then also you can consider fixed prosthesis. But if the patient is not willing to spend and they want overdenture solution, because comparatively overdenture solution is economic compared to the fixed prosthodontics, you need minimum 10 mm of the space. So at times what you have to do, if the bone is not, if there is 8 mm space, you might need to do the alveoloplasty. What is alveoloplasty? Well, alveoloplasty, basically you have to trim the bone and you have to get more space between the bone so that you can accommodate the overdenture solution. Because I tell you, overdenture solution, it needs like you have to put implant. Over the implant, you have to put the overdenture abutment, whether it is locator abutment, whether it is overdenture abutment, you have to place over the implant. So that is the minimum space you need it. Okay, so again, I haven't talked about anything about the thing. Only thing you are analyzing right now, inter-arch space. Inter-arch space is very important to decide the prosthesis part. So the first thing comes is the CBCT for the evaluation part. Once you see the CBCT, the bone availability, you have to evaluate clinically what is the inter-arch space of the patient. So you have to, of course, apply various like centric relation on the patient, centric occlusion. Patient should be in the relaxed position, and then you have to measure the inter-arch distance of the patient, and based on that you can take a call of the different prostheses available. So in Zimmer Biomet, these are some solutions which is available. Fixed prosthesis, when we are talking about patient is in a condition of partially edentulous cases, then of course we have fixed prosthesis available, multiple angulated abutments we are having and everything, multiple ranges there today, but we are focused on a full arch solution. So full arch solutions, which will be from top 4 solutions, will be the full arch solution. Starting from the top, we have the narrow diameter implant retained dentures. So we have in the patient, when normally anterior ridge you will find the bone is very thin. In such a scenario, there are we have the narrow implants available, and in those narrow implant you can give overdenture or locator abutment over those implants. You also have a overdenture solution available in the implant retained thing, which is a normal wide implant basically. So that is what this is most common overdenture solution. This is for the rare cases. For those cases, we have to use this. Okay. Now we will talk about implant or bar supported overdenture. So here, what happens? You have a bar which is connected to the implant, but this particular denture, it can be removed by the patient himself. Okay, so patient can remove the denture, and then they can clean this particular bar, and they can remove any excess calculus or plaque available, and then they can use and they can maintain the hygiene as such. Okay, so basically these are for those patients who cannot maintain the hygiene, or they lose the teeth only because of the hygiene purpose. There are people who have very saliva, they have certain pH of saliva which causes the plaque accumulation more compared to the other patient. In such patient, if you don't give the cleaning option, the patient will never ever feel fresh. If you give the fixed restoration to such patient, they will always have an issue of not feeling fresh, or they will always have an issue of having issues with that. So now and to talk about now the lip support part, we also need to see whether the this is a transition line that is visible or not. So if you see in this particular slide that the transition line is not visible, so in such scenario, fixed hybrid prosthesis is that we have a good ample amount of inter-arch space, and then here the doctor have given the fixed prosthesis available. Okay, we also have to think about the angulation also. Sometimes the bone have resolved too much buccally, so in that scenario you have to think about whether when the patient is smiling, whether the transition zone is visible or not. This is another part to be taken care of. And again, there is a classification by Carl Misch. In this classification, well, it has been, we have also different factors to classify the overdenture supported and what type of implants and how we are placing the implants, and different types of abutment anteriorly which, like, by correcting the angulation from abutment, you can even get the interarch space to be reduced, or to reduce the biomechanics or the force impact. Also, you can use the right abutment, and you can exactly get the angulation of the teeth. So you can also refer to the previous pictures of the patients, and even though the bone is dissolved, you can choose angulated abutment to give the same desired smile, or same desired like the same visit the patient was having 10 years back. You can exactly copy the same thing with the various solutions available. Uh, so now I am coming into the case discussion part. It's very interesting case which was shared by Dr. Amy Riddell, and I really like it because the best part of that is that how the analysis has been conducted for this particular patient. So this particular patient was 80-year-old male. They was having on medication. The issue which was facing by basically the ill-fitting prosthesis. Okay, this is very, very common. Even in, I think I go to any part of the country, I have seen the various countries. So this is a very common scenario which I have witnessed in this particular case. So let me just show you the history. In 2018, the full mouth extraction and the annuloplasty done in order to attain the proper interarch space. And then the patient come up with, after 6 months, the patient come up that the lower denture is not fitting, and this thing. So basically what happened that ideally what we did the denture, but the patient come up with a complaint that the denture is not fitting and stuff like that after 6 months only. And then what we did, that chair side pickup was done, and then implant was placed at the place of 2.2 and 2.7, and then chair side pickup was done, and patient was sent back. Okay, then what happened? The patient was having the pain at 2.7. Attachment is experiencing a pain, and here what he see, like new attachment was picked up at the chair side, and here various type of inserts was placed, and here if you see the lower denture was also not retentive at all. That is what the patient complains. And again in 2021, finally, this is basically a recent case, and here the attachment was picked up, and then a lot of things was done, and then again follow-up was done. So let me just show you the case, the couple of pictures also. So what the doctor did, so Dr. Amy Riddell explained that basically here the problem was a loose denture and the poor retentive implant placement here. And why this happens? Because in the first appointment, when she did the chair side pickup, they come to know that there is a different height of the abutment. So difference in the height also sometimes result in some type of complaint in the patients. So she just figured out one issue, and then she resolved it in the first appointment. But when she go in the later appointment, then this is what she came to understand, that because of the height part. Because see, if the one part is, let's say, lower, so the denture will be fitting on the left side, but the other part, if it is taller, the dentures will not be fitting. So that particular implant will be experiencing more force. So this seesaw is a very good example to understand those things. So then in the later appointment, what Dr. Amy Riddell did, she changed the abutment height to make both them equal. And then finally, the patient was managed to give them at least some retention. So the longer abutment was replaced with the shorter, and then you will see that there is something equal, equal height was given, and then she managed to resolve it. So again, patient again come and he was not 100% satisfied. Then again the root analysis was done, and then the what patients come into the conclusion that ideally for this particular patient, the best solution will be to give them at least 4 implants and a fixed prosthesis for him. So, well, Dr. Amy haven't done it yet for the patient. She have just changed the abutment as mentioned, and she have given the relining of the denture on the equal size abutment. And of course, the patient was not okay with the spending so much money after 2.5 years, and this can happen with anyone. So it's very much real scenario which she have shared, and at the end she have concluded saying that we have to, whenever we are having a consultation with the patient, it's very important to do the consultation properly. Understand the patient financial capacity. If the financial capacity is good, let's keep all the options open in front of patients. And analyze the interarch space, analyze the Cbct, analyze the model, show them all these solutions in front of them, let them feel it, pick it up, and then based on that, we have to make them decide. And try to also show, like, try to take these things also into consideration, that if you think that overdenture solution is the right thing for them, what is the angulation you are giving, what is the height you are giving, and what type of bite patient was having, the reason why the teeth was lost, whether it is bruxism, whether it was something else. So these things need to be considered for planning, and that's how that is the main thing which she addressed here. Now, in Zimmer Biomet, we are having a solution which we call over-denture attachment. It is soon going to available in many APAC countries, and I think in US also it's already available. But in many countries, it's the regulatory process, registration process is going on. So I just wanted to highlight here that it got a very good retentive system, and the coating here is zirconium nitride abutment coating, which is very much biocompatible and having a vertical height for 3.17. The best thing is that you have the 6 different options for the retentive inserts here. So even if the mutual angle between the 2 implant, it is 20 degree, means the per implant it is 10 degree tilted, then you can use this extra light or medium light force, which can which can bear this much of force depending on the angulation. We also have an extra light version which can compensate 20 degree per implant. So total mutual the angular correction can be done, which is around 40 degrees. So you have the elastics for those also available in this overdenture system. So this is something to consider from Zimmer Biomet. Now we are moving into the fixed solution. So fixed solution is altogether different galaxy, different universe we are entering. So with the interest of time, I will just try to highlight and I will restrain my topic to the discussion which is today. We have covered the overdenture solution. Now we will limit our discussion to the fixed solutions. Now the history started Dr. Zaab and Jansen, they have given 2 different designs from 1985, and then they started giving acrylic framework over the metallic bar, over the different type of metal bars. Okay, so this is the wastage. So what is important here, that how does the prosthesis looks like? That is number one thing to take care when you're talking about the fixed or removable. What are the decision making? Well, we have covered those, but just to cover the things to consider when you're giving the fixed prosthesis: aesthetics, design concepts, and general surgical guidelines, which you have to take into the thing, where you have to place it, what type of solution you have it. So those things to be covered. Now, before going everything and why we are talking about all this, see, sometimes it is a psychology of us that if we have given the fixed restoration, it is the strongest of all. But let me tell you, loose screw, fractured screw, loose framework, fractured framework, these are some catastrophic failure which can occur. So again, there are many doctors who say that if if there is certain challenges in the fixed prosthesis, if there is certain limitations, and if you're not able to get, if overdenture is something which is ideally advised, whether it is inter-arch space, whether it is a cleaning issue, whether it is a history of the teeth loss, you should consider overdenture solution, because these are some issues, screw loosening, screw fracture, which is very tough to manage, a fractured bar, fractured framework, something like that. So a very correct planning is important. Okay, just to highlight some prosthetic complication, here you will see a distal cantilever part, which is you can see that majority of the distal bars are fractured because of the overloading. So now cantilever, so just to like everyone is on same page, I just to highlight the cantilever is that part of the denture which is not supported by the implant. So in such scenario, that particular thing will result into the exponential force. So you can see here on the picture on your right side, if 25 pound force is applied on the cantilever, distal end of the cantilever, that force will exponentially be exerted on the abutment and the implant. At around 3 times the force will be on the this fulcrum implant, and the 2 times the force will be on the opposite end of the bridge or the bar. So you can expect that how much force will be exerted. So it's always better to reduce the cantilever. Cantilever is the main culprit whenever there is a frame fracture. I will talk about in the further like what are the solutions which we have it to do the cantilever. So again, another example to show you that what frame, like how the frame is getting fractured, and how the situation, it's getting bad if because of the more cantilever length or not correct planning in the fixed processes. So now again, there are three studies I just wanted to show you to just give you a brief overview about different types of fixed process prosthodontics or fixed prosthesis over implant from the field. So there are these three studies shared by Dr. Carl Brago. The first one is to show whether our fixed prosthesis was successful or not. This was done on the Brainmark implant. So just to show you quickly the results of that, basically 15-year follow-up was done. There were a lot of patients which follow-up was not being continued on 44 patients, but 37 patients out of them, 5 were fixed, were failed. So out of 37, 5 were failed. So roughly you will get a 90% success rate of the fixed prosthodontic, which is still acceptable. 9 out of 10 were having a proper success rate. But what type of failure you have seen in the, so veneer fracture, okay, or time-related fracture was observed in these things in these particular cases. So which is again a good sign. So that is the reason the fixed prosthodontics was considered. Now we talk about the evaluation in the mandible implant. So in mandible, different type of laser welded titanium framework and the gold alloy framework was studied, has been done. So I tell you, gold alloy was one of the standard, but just because of the cost factor, it was not used much. So this particular study was was done, and that the gold alloy framework, which is done, which is basically via a casting procedure, and here this is this one was laser welding was done by the titanium bar. So that is how we have delivered that. So now what was the conclusion? Let me just jump into that. Here you have seen the framework fractured of the titanium, but what we have observed, or of course veneer fracture you have seen in the titanium, but if you talk about in the gold one, you have seen in the bone loss around the gold framework. So now what is the thing you have to understand? See, somewhere this particular study is highlighting that the casting is not giving the implant to abutment smooth connection. Casting is something which is directly transferring the force over the thing. So that's the reason you're having the bone loss. In titanium welded group, yes, you are having veneer fracture. What is the solution of the veneer fracture? You just replace the veneer with another crown, or you repair the hybrid denture. You are having screw loosening. What is the solution of the screw loosening? You will have the screw to be replaced or something like that, or you can have the close follow-up with the patient. Okay, later I will talk about the follow-up also, but these are something which is preventable whenever we're talking about that. So titanium is showing the better or the positive sign compared to the gold or the casting framework. Okay, this is something which Dr. Carl Brago have highlighted, which we call it a one screw test. So what is a one screw test? If you put the screw here on the right side, the other, which is the opposing part of the hybrid denture or it's a bar or anything, should go passively. There should be no gap. If you see here, there is a gap. There is a small gap which is clearly visible. Or sometime you have to put some force to put the screw. So this is called the one screw test. What is one screw test? Again, just to repeat if you put the one screw in any of the implant, the remaining 4, let's say if it's a 5 implant case, the remaining 4 implant, it should go passively inside it, and then once you lose the screw, it should come out very easily. So that is basically a one screw test, and if any bar pass this test, whether it is cast or milled bar, or it is a titanium laser welded bar, it is good. It is good to supply. So that is what Dr. Carl Brago have advised in this study. So now titanium milled framework is something which we all are doing, which is an advanced version of the bar, milled bar, which various labs are providing, including the Bellatech lab, which we have it in US. So what is the advantage of that? It's an excellent corrosion resistant, the titanium and the titanium alloy, which we have it. They are excellent corrosion resistant. They have the low specific gravity, biocompatibility, and they have all the mechanical property which was previously given by the cast gold alloy. So things to consider, and of course low density, high melting point. This is something which is ideal for having any denture over that. So this comes to the last study which I wanted to share with you. Around 20 years of analysis was done over the various osseointegrated implants. So the idea why this study was shared is to tell you that there is no we are not into the final conclusion of this, whether the fixed hybrid prosthesis is best for implant, whether the removal prosthesis is best for the implant. Here, 264 patients, they were having one edentulous jaw, various 35 maxillar, 29 mandible, 11 mandible maxilla. A lot of things were variety of patients were considered, and it was the lot of outcomes was categorized under anticipated and unanticipated prosthetic and biological event. And what is the conclusion for this study is that intervention is needed at the time of follow up whenever you're calling the patient. So now here the conclusion is that you have to understand the variety, like for example in the first appointment itself, what is the patient's medical conditions, what is the patient's psyche, how acceptable the patient is to the changes what they're going to face it, and you have to recall the patient. See, we are not God. We can just do the study and we can assume it, but the appointments of the patient is very, very much important. So we should call the patient, let's say quarterly once, to visit, to check whether everything's going as per plan or not. That is something which is very much important which is being done, and that is what in this study also is being shown by Dr. Carl also, that patient follow-up is very important. Because see, just to give you example, if the screw is loose and the loose screw, if it is not taken care, it can lead to the screw fracture. That is something which is common. Till now, we have I know in Zimmer Biomet we have we have a short steel connection. We have a friction fit there. We have the minimum screw fracture till date. But again, if we talk about in general, the titanium build framework or the fixed prosthesis, screw loosening is something which needs to be taken care. So the patient should become. We should check all the screws, whether the screws are, if they need replacement, if the screw is having some issues with that, we should do it. And definitely in the first appointment itself, you should have that 5-year service cost included in the patient consultation, so that they will have the proper see. So even if the patient is buying a car or luxurious car and all, they know the service needs to be done. Even if you're buying the Mercedes, if you don't service properly, you will have the issue. So simple as that. So patient, you have to make them understand. Even they are having the costliest bar available, whether it's a Malo bridge, whether it is any best fixed hybrid available, they have to come for the follow-up. So that is the main point which was shared here. So now last thing to cover, the different sorry, we all understand there are different type of force mechanics. So the day when you started the implantology, we know the natural teeth and our implant, the variety of forces are which are playing the role whenever the patient is eating the food or they are talking, they're speaking, a lot of different type of forces occurs. So when we are giving a fixed hybrid restoration, we have to understand the bone availability. We have to take a lot of things into consideration while placing the implant. So now here I'm going to talk about some solutions which we have, we call it tilted implant solution, which is a DM2 protocol or the revitalized protocol. So quickly, I will just cover this protocol, what it is and what is it for. So basically this protocol is to one is revitalized, which is basically directed towards the TSV implants from Zimmer Biomet, and we have the DM2 protocol, which is very much like it is having the low profile abutments from certain or from the Biomet implants. These both protocols are basically effectively utilizing the bone availability, the limited bone available. Like for example, for the mandible, at times the posterior bone is dissolved. Like for this particular case, if you see here, the posterior bone is dissolved. The patient is having great immobility of the teeth. In such scenario, you should have a solution in which you place the implant here and you can reduce, you can do the minimum cantilever, and then you can give the solution to that. So let me just show you quickly what I'm talking about. So you have the cantilever. So there is something called AP step. So what is AP spread? Let me highlight here. AP is basically the anterior implant and the distal implant. So that is particularly the length is X. That in that particular, you can have 1.5x the length of the cantilever. So you should not exceed the length more than that. Let's say if it is 10 millimeter, you should not go to more than 15 millimeter as a cantilever distally. That is what it is advised, which is something acceptable in the patient's mouth. So, but imagine if this thing is also not possible, you cannot go, you cannot give straight implants. Then in that case, you can also think about tilting the implant. So you can see the right side and X-ray, in which what we did, we tilted the implant. Why? Because to reduce the cantilever. See, our AP spread rule is saying you cannot go more than 1.5 times, but if you go, but if it is still better if you have no cantilever. So if you can clearly compare the picture on your left side and the picture on your right side, that you have reduced the implant number. Okay, the picture on the your right side, the implant number is 4. Picture on your left side, the implant number is 5. But here, if you see, the cantilever is there. Here, if you see, the cantilever is minimal. So ideally, this is the basically the solution for limiting the distal cantilever. And you can see how the denture will look like in the patient mouth. And this is, and if you see the denture, the other denture, again, what we have learned in today's presentation, that the cantilever is something which will always put load. So let's say if you're giving 25-pound force on the distal end of the cantilever, it will multiply 3 times on this implant, and it will multiply 2 times on this implant. So this will not be the case here. Whatever the force we're applying here, it will be uniformly distributed among all the teeth. Okay. These are the limiting structure which you have to prevent. In the maxilla, you have to prevent the maxillary sinus. In the mandible, you have to prevent the mental foramen. Apart from that, we all have studied the basics of implantology, glitter palatine artery. We have to prevent the nerve. We have to prevent the lingual curvature. So these are things which can be prevented by tilting the implant. So now, things to be considered is whenever you're doing tilting the implant, just quickly, I just wanted to highlight that minimum bone height is 10 mm. We talk about maxilla. When we talk about mandible, the minimum bone height is 8 mm. Again, the width should be 6 to 7 mm here, and the width of mandible is again 6 to 7 mm. This is something which is important to understand if you are planning to place 4 implants supported solution, which is a fixed solution we are talking about here. Again, the same thing, like how we can prevent and how we can reduce the cantilever, how we can tilt the implant, and we can prevent the thing. And this, there is a term called cross arch stabilization. So you normally you should not give a unilateral. As per the studies, you should not tilt the implant unilaterally. You should tilt the implant both the side, so that there will be a cross arch stabilization. Okay, it's like a tent effect, people call it. So whenever the tent is there, it will mutually the force will be distributed equally, and then that's how there will be no detrimental effect on the restoration. So now, again, this is the AP spread part I've covered. So the very important, we all know the benefit of the tilted implant things, but the very important thing you should note that the abutment plays a crucial role. Why? Because when you are limiting the number of implant from 6 to 4, reducing the number of implant, then the importance of the abutment plays the main role now. Here I would like to highlight the implant abutment which we have it, tapered abutment, and we also have a low profile abutment which is similar to the tapered abutment which we have it. These abutments are basically having a 45-degree of correction. Means if the implant is tilted 45-degree, this can be corrected by placing the right tapered abutment. So we have 2 options available: 13-degree and 30-degree and 15-degree abutment, which can correct 45-degree, 45-degree, 30-degree respectively of a different tilted implants. And just to highlight some feature of this implant, because see, we all now understand that the abutment should be like that. It should bear the temporary denture conversion over the temporary abutments. And later, once you give like a digital portfolio, once you follow the digital solutions, that abutment should be able to adapt different timelines and different types of forces. So abutment should be capable enough to adapt all these type of forces. So I wanted to highlight that there was a test being done by the Zimmer compared to the competitors. 30% it is stronger compared to the nearest competitor. And if you talk about the compressive strength testing, if you talk about the footing strength testing, it was 25% stronger. So compressive strength, which is basically how much compression force is generated in the oral cavity, the 30-degree abutment was 80% stronger. And when you talk about fatigue, like how much cycles it was like it was bearing that fatigue strength, that is 25% stronger. And this, if you talk about the coping screw also now, the coping screw was 50% more torque it can be given or compared to that. So this is the two thing which is very much important for any tapered abutment to survive. We need them that they should be able to bear the compressive strength, and they should not get fatigue. They should not get, with time, they should not wear and tear. So the fatigue strength defines those properties of the abutment. And if you talk about the coping screw should be, able to bear more torque. So that is what it is talked here, that it can bear more than 50% of that. Again, there are another properties that it is having the low profile delivery tool, which is just 8 mm. It is having a small hole also where you can put the floss, and very easy to take. So it is something which is always preferred, that it is like this thing to place it, to take it out. It's very easy to place it. And again, you have the different, additional. If you talk about the height which we have available, angle multi-unit abutment, we have 1 mm, and we have a straight multi-unit abutment 0.7 mm. So this is very easy to handle it, very easier to place it. It's not much bulky, it's not having that appearance, even though it is stronger. But the height, if you talk about straight multi-unit or angle multi-unit, it is not that much. So that is also giving easier for user to place it. Okay. So again, these are some competitors' pictures. The user, how they are having, collar height, which is 3.5, which is quite longer, and they are having different angles. Okay, so this is something which is just to show you that what are the advantage you are having with Zimmer Biomet. Finally, we again to tell you that we are having similar like tapered abutment. We have a low profile abutment available for the Biomet implants. And over that, again, we have a DM2 protocol, which is basically also we follow a digital protocol, which is beyond the scope of today's discussion. Maybe in the coming sessions, we will talk about our different digital workflows to discuss upon that. So to conclude, we have the revitalized and the DM solutions available. Again, these over this solution, you can either give a hybrid denture or a bar, or we also have a digital workflow available in a different countries. In many countries, it's so we have this, we call it Belatech or ZFS Gentech solutions available. So in many countries, they are under process of approval. In India, it has already been available. So over this type basis, you can even it's a very open system. You can use different type of libraries, be it 3Shape, be it ExoCAD and all. You can design the processes over that. So our Zimmer Biomet, you are not restricting. There is nothing closed system is available here. You can use these type bases, and you can use our scan bodies to follow the digital workflow over that, and you can give the digital restoration. You can design the desired bar over our type bases, and you can give the restoration to them. I know it's altogether different topic, but just to highlight that the solutions are available, which you can use and we can give in the years to come. And finally, I want to refer the two Dr. Amy Riddell and Dr. Carl Drago's on-demand webcasts. If you have time, please go visit our Zimmer Biomet app. We have these on-demand webcasts available. You can view at the comfort of your home and whenever it's time comfortable with you. A lot of things have been covered. I'm sure this is going to benefit you all. With this, I want to. I hope that I managed to do justice of your 1 hour time and managed to resolve the query. I will try to answer some questions if you have with the best of my knowledge. Thanks everyone. Over to you, Amy.
Thank you so much, Syed, for all inspiring us and teaching us about how to what to look out for when we're doing full mouth rehab. What is better to use? What are criterias for removable versus fixed prosthesis? We will now move on to the Q&A section. So for those of you out there who are listening in, if you have any questions, please feel free to ask your questions and then we will answer them accordingly. Okay, so Syed, should I go through some of the frequently asked questions? Both of us, we always get questions, actually all of us,
Yes,
from our
of
dentists. So
course.
maybe we can go through some of these questions that are commonly asked.
Yes, Amy, please.
Okay,
Yes.
so the first question I have here is, can you explain a little bit about the use of angled tapered abutment and in which case do we use them?
So, Amy, what I mentioned actually, angle tapered abutment, basically the normal terminology in the market, it is a multi-unit abutment. Why multi-unit? Because there is a screw which is always fixed in the abutment and they are always carried along with the abutment. So these multi-unit abutment, in Zimmer we call it tapered abutment. These abutments are very much important because now we are entering into the tilted implant concept. So again, go back why we are tilted, because the bone is not available accordingly. In maxillary sometimes the angulation of the bone is too much. In we have the mental foramen in the proximity, sometimes we have the sinus floor, patient is due to the grafting. So we have to tilt the implant nowadays, and once you tilted the implant, you have to place an abutment so that you can give the prosthesis in the parallel way. So that is the tapered abutment is a boon for all of us. And with using correct angulation, we can get the angulation corrected and we can give the prosthesis over that easily. Whether it is digital, whether it is fixed hybrid prosthesis, we can easily give it to them.
Yeah. Okay, thank you. The next question is, the use of tapered abutment and low profile abutments is recommended by Zimmer Biomet for hybrid prosthesis. How does that compare to the use of customized abutments that fit in directly to bone level abutments?
Yeah,
Implants, sorry.
it's a very common concern. Even to be very honest with you, this is a very common. Like in my previous experience, also I have interacted with a lot of universities, a lot of people in India's where we had many courses and all. We have seen that the castable or the customized abutment, this is something which is lab is very much comfortable in doing it, and the lab have they sometimes they try to push the doctors to just go with the customized solution because it's easier for to give the solutions. Okay, but the problem is we should not do that. The reason being, because if you remember the one screw test slide I have shown you, that at times it is very common that when you do the one screw test, the bar will not be passive, because it's always advisable that whenever you have the this framework design, whether it is casting, whether it is laser welded or milled, that bar should fit passively. And one screw test means you just put the screw anywhere and there should be no gap between the bar. When you do the customized or you do the casting solution, in that the chances of having the gap, the chances of having the screw active is very common. And what will happen, it will gradually make the screw loose. It will gradually if again follow-up is not being done, it will cause screw fracture. Even though, let's say, God forbid, you have the stronger screws, let's say for the Zimmer screws are very stronger, you have the tapered abutment very stronger, if everything is goes well, but the implant will fail. So everything is good and well, but the implant, there will be the cervical bone loss and the patient will not follow up, then that will be the problem. That is a nightmare for the dentist to replace the implant. So that is something that's been observed lately, and this is something to plan accordingly. So it's always advisable to go either with that we have the digital solutions available or something. Or yeah, one more thing to mention, that if anyhow you have to do that chrome cobalt bar or something, it should be done not at the implant level, it should be done at the abutment level. Let's say you can give the tapered abutment, over that you can do that, so at least your implant will be saved. So that is something which is being shared by the doctors lately.
Okay, thanks. The next question is, can you explain a little bit about the similarities and differences between the locator abutments as well as over denture abutments that you just mentioned earlier?
Yes, yes. So locator is something which we have seen in the market. Doctors are using it like a common overdenture solution since decades by now. The reason locators and overdenture, see, similarity is that both are very much similar. 80 to 90% they both are same. And compared to the ball abutment which was used earlier, this is something which is being prevalent because here you will never see a fracture of the abutment. However, in the ball abutment, you must have seen in the ball abutment there sometimes the ball is getting fractured. Oh, that is a nightmare for the dentist because once the ball is fractured, it is tough to remove it, and the patient have a lot of concerns in that and all. And locator, you never have those things. Similarity in overdenture or locator, they both are similar. They both can do the angle correction about 20 degree to the 40-degree part. In overdenture, you have one advantage of the retentive elastic which is available in overdenture. It is for the 40-degree one, you have little bit more option of retentive elastic. And basically, what if you talk about where it have a role? See, when you have the more option in the retentive elastic, you like if the one implant is straighter, one implant is tilted, the divergent implant can have the lesser retentive feature elastic, and the straight implant will have the more, or you can say dual retentive elastic. So something like that you can play around. You have more options of retentive feature with overdenture.
Okay. The next question I have here is among heights or angulations for a two implant retained overdenture to function properly.
Yeah, yeah. So actually, yeah, that is what I was discussing. So basically, in order to have a proper functioning of the two implants, it is very much important that you have to have the similar height. Let's say one implant is placed little bit, subgingivally, or it is, you can say maybe at the bone level. Another implant is, let's say, supracrestally above the bone level. So you have to choose two abutments like that the height of the final abutment should be same. If you remember the case which I have shared with Imran, there the different height was causing the issue. The patient was having the what you call the longer abutment implant. Patient was complaining pain. So see, normally what happened, doctor ordered 2 collar, 2 collar, but they don't analyze that the one implant is supracrestal or other implant the bone resorption has occurred. So we have to calculate that part also. If let's say implant is there, you can order the lesser height locator abutment there, and then the overall height will be similar, right? So that is number one thing to take into consideration. Number two thing is that the angulation of the implant to be taken care. So you all know, ideally there is no mutual 20 degrees. Sometimes it is very much common. One implant is straighter, another implant is, let's say, 20-degree tilted. So which one is the divergent implant? You have to use the less retentive elastic in that. That is the key point which Dr. Amy Redan cover, and that is majority of the prosthodontists also advise that whenever you're placing two implant, you have to make the height equal, and the less retentive elastic will be on the tilted implant. That is the ideal for the longevity of any overdenture.
Okay, so we have a question here. Can you please repeat the AP spread if possible? Maybe show up that slide and then maybe explain a little
Yes,
bit
yes,
more.
yes, yes. Let me just quickly go into that. Yeah. So let me share. Okay. Okay. I hope you can see that. Yeah.
Yeah.
Yeah. So basically, AP spread is basically the antero-posterior spread of like basically it is this formula is used to calculate the maximum cantilever length. Let me tell you why it is so we are talking about. See, sometimes patients, doctors, they don't have the flexibility of tapered abutment. See, if you have tapered abutment, you don't have to worry about antero-posterior spread because you can tilt the distal implant, forget about the cantilever. But let's say if you have the straight implant only available, or let's say you have the 20-degree tapered implant available. So in that case, you have to place the implant as if the, let me just make the slideshow and okay. Okay, I hope you can see that. Yeah. So if you see here, the distal part of the last implant and the center of the most anterior implant, that is the X. You are measuring anterior-posteriorly. You are not measuring on the arch. Okay. So that is the X. You can multiply that by 1.5. So let's say it is a 10 millimeter. When you calculated this distance, it is 10 millimeter, and then the distal part of that x, which is, it should be 1.x. So you can give the cantilever to that extent. So now again, you can give means the force, like let's say again the 25 ncm force is applied here, which is normally generated in the human body. And this particular calculation, we are talking about our Zimmer implants mostly. So we cannot talk about another company implants. So this is mostly on our Zimmer implants basically. And mostly the premium implants also follow this criteria. Here, you see that they can bear that much force. So 25 times 3, which is 75, times 2, 50 ncm force will be generated, that is within the limit of the implants. Patient prosthesis will not fracture in this particular scenario. That is what it is mentioned by this what you call cantilever length or anterior posterior spread. But if you increase more, if you go more, or if you increase that, then the risk is more. So that is what the studies have suggested, that you should not exceed the cantilever beyond this. I hope I covered it, right?
Yeah, that's great.
I mean, to answer
That's
that.
good.
Yeah.
That's good. Yeah. Thank you. Okay, the next question is, what are crucial points to highlight in first appointment when the patient comes and visits you?
Yes, yes. So the most important, the most important thing in me is again, like I mentioned, that like we have to understand the patient's paying capacity. At times, patient looks very rich, but they don't want to spend a single penny. At times, the patient doesn't look rich, but they can spend a million. You never know the capacity. So please understand. And also sometimes patient will ask, yeah, why you're asking me all this kind of stuff. Then you can tell them, or you can show them the options, that we have the options available from the denture, which is hardly $50 or $100 the costing. And then you can go about the multiple solutions, which is about thousands of dollars and all. And then you can tell them the like which thing is under your financial capacity. After that, it comes the CBCT analysis. It is come that interarch analysis, and then again the bone preservations, the bone architectures. So this thing comes secondary. Once the patient is ready, so then you are free to decide on. So let's say the patient is not ready to spend at all, then better to just give them the denture, or the single implant supported over denture, or two implants supported over denture, which is actually WHO have advised that at least you should give a single denture in mandible, single implant in the mandible, whenever you are giving the full mouth denture. So that is the instructions from the WHO. So that is the minimal treatment modality which ideally you should give if you know how to place the implant. So this is something which needs to be considered, and patient need to be counseled in the first appointment. I think that is something, the gist of what we have discussed today.
Okay, Syed, thank you very much for the lecture today, enhancing our knowledge regarding restoring full arch, fixed versus removable prostheses in Zimmer Biomet. We look forward to your next lecture. To all who have participated, thank you very much for joining us.
Thanks, Amy. Thanks.
Thank you. On Monday, 28th of February 2022, we have Dr. Tanvi Dut to speak on the topic implant loading protocols for this product and clinical case presentation program. Please scan the QR code on the screen